Hello, health psych students. This is part one of the eating disorders lecture. Alrighty. If we had the clickers, I would be surveying you and asking you who has more prevalence of an eating disorder, men or women. And the answer to that is women, but men do get eating disorders, and they're actually pretty equivalent when it comes to binge eating disorder. Racial differences, once upon a time, we thought there were racial differences, that this was just a white girl, white woman phenomenon, but that was mainly because they were looking at treatment-seeking individuals, and they weren't going out and doing epidemiological research. And now we know that eating disorders can affect people of all races. So these are the DSM-5 definitions for the 3 eating disorders that we are going to cover. Anorexia nervosa. Anorexia, literally the word means lack of appetite, but it's not like true anorexia, like let's say somebody gets sick and they lose their appetite because they're sick. The nervosa part means this is a psychological disorder. And so classic anorexia is where individuals are restricting their energy intake, their food intake, relative to what their body needs, and that leads to significantly low weight. The old DSM used to have a weight categorization of below a BMI of 17.5. I'm so glad they got rid of that, because sometimes individuals could have larger bodies and still have anorexia and be weight suppressed and would fit criteria for this diagnosis, but their actual body weight is not necessarily less than 17.5 BMI. There is an intense fear of fat and being fat, or gaining weight and getting fat. And there's usually a disturbed body image, this idea of individuals seeing himself, herself as being much larger or much fatter than they actually are. The 2 subtypes, the classic is the restricting subtype. So that's usually what people think about when they think about anorexia, where an individual is dieting, or they're totally fasting and not eating, or they're restricting their food intake, or exercising to burn calories, but not necessarily engaging in any purging behavior. The second type, the purging subtype, would be where an individual is either making themselves throw up, or they're abusing laxatives, or exercising very compulsively to burn calories. In some way, the purging part is to try to undo what has been consumed. Both are very dangerous. I will let you read this. This is a client of mine that was struggling with an eating disorder. I'll just let you read it. So this is a client who was in a stage of treatment, acknowledging that engaging in the anorexia behavior was bad for her, but still needing to hold on to the actual behavior. And there tends to be like a tip that happens in treatment, that once an individual is able to label and actually conceptualize the eating disorder as the enemy, then you see a real tip in treatment. But in this case, she was still wrestling. Okay, so the second eating disorder is bulimia or nervosa. And it took me a while to kind of wrap my head around this, because the term bulimia means oxen hunger or cow hunger. And I was like, what does this have to do with people that make themselves throw up a lot? But it finally occurred to me, it has to do with the 2 stomachs, that cows have 2 stomachs. So they eat, the food goes in, and then they regurgitate, and it goes into a second stomach. So it's really, bulimia has to do with the regurgitation. This is when an individual engages in repeated episodes of binge eating. And binge eating is usually defined as really large quantity of food, very short period of time, very rapid eating, oftentimes very secretive eating. And then engaging, feeling anxiety after the binge, anxiety of like, oh my gosh, I just consumed, I don't know, 3,000 calories. Which are really kilocalories, by the way. But I've just consumed 3,000 calories and I'm all anxious and I'm going to get fat. And so then the anxiety is relieved by engaging in compensatory behavior. And so a common compensatory behavior would be self-induced vomiting. I know when I worked in a inpatient hospital setting, there were patients that had calluses on their knuckles, and the calluses on their knuckles were from putting their finger down their throat, rubbing their knuckles up against their teeth when they would engage in self-induced vomiting. So horrible kind of side effect of that. Other forms of compensatory behavior, really compulsive exercise to burn calories, laxative abuse, which is very, very dangerous and is actually not even effective at getting rid of food. And then sometimes other substance abuse, like using diuretics or using amphetamines and that type of thing. And what I want you to understand here is that this cycle is a negative reinforcement cycle. So there's usually distress, and then distress leads to the binge eating. The binge usually has some kind of function of helping a person dissociate, or it's pleasurable. It has some kind of function, reinforcing function to it. But after the binge, there's a tremendous level of anxiety, and the person wants to escape that anxiety. And so then there is removal of the food by self-induced vomiting or laxatives, which relieves the anxiety. And then I want us to think about it. That's the negative. That's the subtracting. It subtracts the anxiety from that situation. But I want us to think through what gets reinforced here. And what gets reinforced is the binge episode. Nobody starts out binging, on 10,000 calories and thinks that that's a great idea. But what happens is once a person starts purging and they get that negative reinforcement, the binge episodes, they either grow in frequency or they grow in amount of food that a person is eating. This idea of like, if I'm going to get rid of it anyways, let me just, enjoy this pint of ice cream or whatever it might be. Okay, so it's negative reinforcement. And that is how bulimia grows. When I work with an individual who is just binge eating, they're not engaging in any compensatory behavior, I always screen for that. And I always warn them, I'm like, okay, don't go there. Don't go there and start purging or abusing the substances or whatnot, because then you create a whole nother problem, a whole nother ballgame. And if it's negative reinforcement, if it is that escape cycle that makes the binges grow, then what we're going to want to do in treatment is exposure therapy. And one way that we do exposure therapy, and I've done this with clients before, is we expose them to foods that would be considered to be trigger or binge foods. So I've sat with people where we eat cake together. I've sat with people where we eat pizza together or ice cream or whatnot. And then they eat the binge food and they sit with the anxiety. They expose themselves to the anxiety, prolonged exposure until the anxiety habituates and it comes down. And once they realize they can eat these trigger foods, these binge-like foods, and they can eat them without anxiety, there's no need to engage in compulsive compensatory behavior. Keep in mind, compensatory comes from compensate. They're trying to compensate or undo. You also get the body image issues oftentimes in bulimia nervosa, where the idea that they are all about their weight or they're all about their appearance. Oftentimes there's that drive for thinness like you see in anorexia, always trying to either lose weight or control weight or not gain weight, that type of thing. Okay, so the third eating disorder is binge eating disorder. It's oftentimes abbreviated BED, BED, but we don't say bed, we say BED. This is when there's also recurrent episodes of binge eating, and they go, and the DSM for some reason defines the binge a little more thoroughly here in BED, but not so much in bulimia nervosa. They say it's more food than would be normal in a short period of time. It usually is done secretively. Usually the person feels a lack of control. Like once they start eating, they just keep going and they can't stop it. And it's not normal overeating. I think most of us can relate to if your family celebrates traditional Thanksgiving meal, most of us overeat at Thanksgiving as an example, but it's sort of like, well, it's Thanksgiving, this is what we do. They say that the episodes have to meet at least 3 of these criteria here. It's either rapid eating, uncomfortably full, and usually it ends when a person is in pain, or sometimes it ends when people fall asleep. There's so much energy in the body used to try to digest food that all the blood flow goes into the GI tract, and then some individuals get lightheaded and just go to sleep. Usually they're not hungry. It's serving a different function other than nourishment. Usually it's done alone and secretively, and oftentimes individuals feel really bad afterwards. So they get that negative affect, feeling disgusted, depressed, guilty, that type of thing. And again, that's why when I'm working with somebody who's just a binge eater, I warn them, I'm like, don't go there. Don't go into purging. has to create distress. So they have to be concerned about this. And then there's a frequency of how often it's supposed to occur to be diagnosable. So reasons that people overeat, I love HALT because it is really valuable way of sort of setting up the beginning of therapy. You have individuals self-monitor their food over time and their moods and their thought patterns and that type of thing. And what we're trying to figure out here is what is the function? What function is the eating disorder serving in their lives? And for a lot of individuals, just to give you some examples, it's a function of control, like so being in a chaotic atmosphere or a chaotic family or chaotic life and feeling like the one thing that they can't control is what they put in their mouths in their eating. I've seen it function for individuals just managing anxiety. I've seen it function managing depression. I've seen it as an extension of OCD. So whenever I'm working with a client with an eating disorder, I always kind of back myself up a little bit and I go, diagnostically, what am I really dealing with here? I had a recent teenage client as an example who really just had social anxiety disorder, kind of a generalized anxiety disorder. She didn't even really want to be losing weight, but she found that after she ate, if she purged, she somehow felt like cleaner, or she felt like purer, or it just felt like it brought the anxiety down. And in her situation, we did the eating disorder treatment, but we really had to focus on more social anxiety. Okay, so HALT. Hunger. If particularly what happens for individuals, if they deprive enough, and this would be the case for all of us. So I want you to kind of imagine this. Imagine that you are so dehydrated and you're out in the hot sun and you're on a hike all by yourself and you don't have water. You would start obsessing about drinking water and you would dream about it at night. And then your behavior could even get what we would normally consider to be kind of disgusting. If, let's say, you happen upon this mud puddle with, bugs floating in it, you'd be down on the ground lapping up that muddy water if you were that dehydrated. Same thing happens for us with food. Our body likes homeostasis. It likes to be nourished on a regular basis. And so if you restrict and restrict and restrict your food, then oftentimes once you start eating after that deprivation, you eat a lot and you eat very quickly. And so it makes a lot of sense of why really bad hunger can lead to binge eating. For anxiety and anger, you see a lot of people trying to manage negative affect. And again, that's why, I talk about like depression or anxiety disorder or that type of thing. But keep in mind that for each of these, there are other ways of getting these needs met, okay? There are other ways of managing anxiety and negative affect. L for loneliness. A lot of times individuals treat food as a companion and a substitute for interacting with other people. And this is where the eating disorders get really rough for people because they're done in secrecy. And to do things in secrecy, you have to kind of isolate yourself. And it becomes like this vicious circle of individuals spending more time alone, but yet feeling lonely and needing human connection, eating in secret. And then a lot of individuals with eating disorders are very self-conscious about eating with other people and having other individuals watch them, a bit of a social anxiety component to it, but then also feeling like people are judging them when they are eating. When I worked in a inpatient, for my master's internship, I worked in an inpatient program for eating disorders. And one of my roles as an intern is I had to have 2 meals a day in the eating disorder program with the patients on the unit. And so I would either go and have breakfast and lunch, or I would go and have lunch and dinner with them every day and just simply sit with individuals and be able to model eating without anxiety, but then also to be there to support them and encourage them and help them when they would get kind of panicky, encourage them they had to eat everything that was served to them, or they would have to drink a supplement. There were all kinds of reinforcers and punishers in the program to reinforce recovery behavior and to punish eating disorder behavior. And again, remember, when we're talking about punishment, we're not talking about being mean, we're talking about decreasing behavior. And then T for tired. This is one I find myself doing at times. There are times where I find myself going and snacking to try to fuel. And I've just had to be more careful over time of like, you know, maybe what I need is a nap, or maybe what I need to do is go to bed earlier tonight if I'm tired and I'm eating when that's really what I don't need. So HALT, I love HALT because again, from an intervention perspective of helping individuals after they're kind of monitoring their eating, monitoring their moods, monitoring their thoughts, all of that kind of stuff. And once they start to realize the function, how's the eating disorder functioning and serving their lives, there are ways of meeting these needs in other ways. And so we start to roll in over time in treatment. How can we take care of this person? How can we meet these basic normal needs that they have in ways that don't involve eating disorder behavior? Okay. So if I were to survey you with the clickers, which we're not doing, and ask you what is more prevalent, what is least prevalent, a lot of times individuals think that anorexia is the most prevalent eating disorder, and that's not the case. But I think the reason why a lot of people think that is anorexia gets the most media attention, and it tends to be known and understood a little bit better than binge eating disorder and bulimia nervosa. So it's actually the least prevalent. Binge eating disorder is the most prevalent. Okay. So we've got a lot of individuals in the US that have anorexia, but I do want to pay a little bit of attention to these prevalence rates. So anorexia is less than 1% of the US population. However, having said that, I think the DSM criteria for each of these are pretty stringent and pretty strict. And I've had issues over time in my career because I've worked with a lot of people with eating disorders. I've had issues with the way the DSM defines these because I find for a lot of individuals, they don't necessarily meet the criteria, but they clearly have an eating disorder, and we can clearly, in a trans-diagnostic approach, we can treat the eating disorder because we're treating the function of it. So this is pretty stringent criteria, and likely there are more people with anorexia kind of behavior, but less than 1%. We tend to see an onset in puberty or later in the teen years. And there's a really interesting developmental thing that happens for girls versus boys in our culture. Girls that enter into puberty earlier than their peers tend to have more depression, lower self-esteem, more body image issues, more vulnerability for eating disorders. Because oftentimes what happens, if you think about our cultural models, particularly lean models like actresses, fashion models, that type of thing. A lot of times for girls, when they hit puberty, their body develops in a way that moves them away from the cultural ideal. They start to develop fat deposits, which are normal on the hips, the breasts, buttocks, thighs, all that kind of stuff. But for a lot of women, they dislike the way their body is becoming to look. And then also, we have research on the fact that women become, after puberty, boys start looking at them, men start looking at them, they start to get objectified and they start to get sexualized. And then oftentimes there are individuals who are interested in being sexual with them before they are ready for it. Okay, so early puberty for gals tends to be bad in US culture. Interestingly, early puberty for guys tends to be better. The sooner that guys grow taller, sooner that guys get more muscular, which are the natural byproduct of testosterone and puberty. Guys who hit puberty early tend to be better athletes. They tend to have better self-esteem and are at lower risk for depression. Guys who are small and enter puberty later are going to be more at risk. They're going to have more problematic with athletics if they're trying to be athletic. They're more likely to be bullied for their small size. So it's just this interesting gender interaction. Bulimia nervosa, about 1% of the population, but you see higher rates in like college students. And then binge eating disorder, about 4.5%. So it is the most prevalent of the eating disorders. And it is related, binging, this makes some sense, is related to early onset obesity. If people are binging and eating way more kilocalories per day than they need, they're going to be more at risk for developing obesity. Okay, I'll let you read my joke. Okay. Okay, I'll let you take a look at this. This is a study that was conducted way back in 1985, but we have replicated it at ASU, and we actually got the exact same results that Fallon and Rosen got years ago, which kind of tells me that body image body image issues are remaining pretty stable across time in our culture. And what you would do here is you gals would look at the gals at the top, you guys would look at the guys down below. And what you would do is you would rate what you consider to be your current body, and then you would rate what you consider to be your ideal body. Sometimes they're the same, sometimes they're different. And then I'll show you what this looks like. Okay, so women in this study on average would rate their current body here, but they would rate their ideal down here below. And this discrepancy, this desire for women on average to want to be smaller, to be less fat, to be leaner, we call body image dissatisfaction, okay? And body image dissatisfaction is the key driving force for the development of eating disorders. It's also called drive for thinness. So body image dissatisfaction, drive for thinness. What I love this study, because down here, if you take a look at what the guys are rating, they're saying that their current and their ideal are exactly the same. They are the way they want to be, but women tend to have this discrepancy. The other attractive is actually asking what you think a romantic partner would find to be most attractive. And they're saying this, not this. The other attractive is, interestingly, what the guys are saying, they wish that they were a bit leaner. Okay, now I want to critique these figurines, and this has been used in research over and over again. We've even done a study and we've used it. The critique for this, though, is that these are more Caucasian or white people body shapes. They do not get big enough. This is not, necessarily somebody who is obese. This is somebody who's just got a bit of overweight. And then they kind of have ethnic faces. So we've used in our research, we've done a couple different things to get around this. There's a scale called the Pulvers, and the Pulvers has figurines that go much more diverse, and they are headless, which is a little weird looking, but and they are indicative of all racial body shapes. So you don't look at them and go, oh, these are African Americans, or these are Caucasian bodily shapes, or whatnot. So we've used Pulvers. The other thing that we've used in our research to get around this is clothing size. And we've got this construct called relative clothing size. I think I've talked about this before, where with women, you do dress size and you ask them their current dress size, and then you ask them their ideal dress size. And if their ideal is lower or larger, you measure that discrepancy as positive, how many dress sizes above or below, or negative, how many dress sizes. For guys, it is waist size, it's pant size, which for you guys, it's usually your waist and your length. And we use the waist size. That relative size has performed beautifully as a proxy for body image dissatisfaction in our research. Okay. Eating disorders have been fascinating for me because they're almost like, in my way of conceptualizing, the perfect mind-body phenomenon of a disorder. And so it fits very well into a biopsychosocial spiritual model in thinking about the causes. I've had people before, when they realize this is my area of research, to go, well, what causes eating disorders? And I was like, whoa, man, there's a lot going on there. I can't name just one thing. The best predictor would be that drive for thinness or that body image dissatisfaction, but it's usually a lot more complicated than that. So culturally, if we take a look at our role models, actors feel a lot of pressure to look a certain way. If we herald runway models, which runway models, by the way, are in the lowest 1% of body mass index in our culture. They are genetic anomalies. And weirdly, we take this genetic anomaly, kind of freaky, one way of thinking about it, and we herald them and we go, oh, that's beautiful, and we should all look like that. And I make that akin to polydacty, people born with 6 fingers. And usually when people are born with 6 fingers, they have surgery to remove that 6th finger. They think it's weird. Is more prevalent in our genetics than the body mass index of our fashion models. So we've got this weird thing where we take this, we're genetics, and we think it's great. Psychologically, you see a lot of comorbidity in eating disorders. And again, that's why when I'm diagnosing somebody and trying to conceptualize their treatment plan, I always back up and look at it's like, what is this? Is this brought on from depression? Is this OCD? I've seen a lot of perfectionism in eating disorders. And I have a colleague who helped me develop a new term for perfectionism, which I think is interesting. She calls it, this is Dr. Catherine Catone, she calls perfectionism romanticized rigidity in thinking. And it's like, yeah, romanticized, like it's this great thing, but it's just really about rigidity. And it's really about having these goals for oneself that are ridiculously unattainable and ridiculously rigid. So a rough way to live. So I do a lot of when I'm doing therapy with clients with eating disorders, I call it in my head, helping them lighten up, helping them relax, helping them lighten up, helping them build psychological flexibility, which remember is in the hexaflex for acceptance and commitment therapy, the ACT model. Oftentimes we see in eating disorders a history of abuse, a history of sexual assault, a history of verbal abuse, a history of physical abuse. And one way of thinking about the eating disorders after having been a victim of abuse, first of all, victimization is a message that you don't deserve to take care of yourself, which is really, really sad. As well as if one's being has been violated. Ironically, what happens to a lot of individuals is they engage in self-punishment and kind of recapitulate the abuse, which is a really sad type of thing. I feel very strongly from a feminist perspective in treating eating disorders that oftentimes individuals are trying to follow some cultural ideal that's ridiculous, or other individuals have harmed them and now they're engaging in self-harm over time. I really like getting in there and helping people get past that. You also see substance abuse issues from a personality standpoint. We've already talked about the perfectionism, problems in coping with stress, problems in understanding one's emotions and how to, in a healthy way, express one's emotions. You saw that passage from a previous client of mine. I have my clients do a lot of journal writing and learning how to identify their feelings and in learning how to express their feelings with me as well as in their journaling, because a lot of times people are holding in a lot of pain and a lot of feelings. Biologically, we've talked about there is a genetic link. And in some situations, there is even not a drive for thinness. There's some interesting research, and then I've seen clients before with this where they don't necessarily want to be leaner, but either food restriction makes them feel good or binging makes them feel good, and it has a function for them. Some of our high-risk groups for individuals, people who are frequent dieters. I've got a current client right now who has a history of an eating disorder, and her parents are pretty significant dieters and really trying to control their weight and lose weight. And they've taken that as parents and put that on their kid, unfortunately. Athletics, there's certainly issues with coaches in some situations, and athletes that feel a lot of pressure to be leaner, thinking that being leaner always means that they would be stronger, faster. So think about runners, think about gymnasts, ballerinas historically are very high risk for developing eating disorders. We know that if people have been teased or bullied or fat shamed, and there's even research on the fat shaming by parents, by siblings, by peers, that is a very strong risk factor for developing eating disorders. There's an article that I have written about in my book, my Fat Talk book, and it's something like, if fat shaming worked, there would be no fat people, because larger people feel a lot of stigma. And if they have been deliberately fat shamed and bullied, it doesn't help people get leaner. It actually backfires and creates more eating disorder behavior, more binge eating, and more bulimia. So the teasing's awful. I do a lot of work with clients thinking back about what were the triggers for the eating disorder. And a lot of times we have to do some treatment for PTSD if there's been a history of interpersonal violence, and also dealing with the fat shaming and the teasing. From a family standpoint, you oftentimes see poor communication, either poor affection or passive aggressive kind of communication, or just neglectful communication of not relaying expectations or whatnot. Families tend to be a bit less nurturing and affection loving. And then again, that issue with food and weight. When I worked in an inpatient program, we were doing group therapy, and there was a young woman who was in our program, and her diagnosis was bulimia. And I remember when she was brought into the program, noticing very quickly that mom looked anorexic and dad was this big burly guy, and this particular teenager had more of dad's bone structure. She had a bigger, kind of thicker body, but I remember kind of noting that mom looked sick, and the parents refused to participate in family therapy, which is red flag. Anyway, so we're in group one day, and we're going around and we're having everybody name their achievements and something that they were proud of. And we get to this particular client, and she said, well, the thing that I love the most, that she got good grades in school, but she'd been a cheerleader ever since she was little. And her squad had elected her to be the captain of the cheerleading team in her next year in school. And she's really proud of it. She's really excited. She had ideas about stuff she wanted to do. She said, but there's that's an upside. It brings me a lot of pride and a lot of esteem, but there's also a downside to it. And she said her mom would not go attend her games or her meets, and her dad was supportive of her cheerleading, but her mom was not. Oh, keep in mind, this mom, by the way, before she was entered into the hospital, this client would be allowed to wake up in the morning and use the restroom, and then she would have to weigh in, and mom would weigh her in, and she'd get up on the scale, and mom would like berate her, like, see, you've gained 3 pounds. I told you not to eat that pizza, kind of stuff. Abusive, right? So anyways, we asked her, have you ever talked to your mom about why she doesn't come to your games or your meets and watch you cheer? And she said, yeah, I did ask her one day. And her mom said, I'm not going to come and watch you cheer because I would not be able to stomach seeing your breasts bounce. Yeah. She, this poor client was actually, her parents pulled her out of the inpatient treatment program prematurely, against medical advice, AMA, because we weren't helping her lose weight. She was a wonderful young woman. We were very helpful with her bulimia. She was not engaging in bulimia behavior, but she wasn't losing weight, and that's what mom wanted her to do. So in that situation, you're like, ugh, okay. Having said that, I've worked with a lot of families where there is a person in the family with an eating disorder, and I'm always careful. I don't want to blame. I want to help everybody in the family get healthier. And in some situations, family members like parents get overprotective or over controlling because they're scared. They are scared that they've got a son or a daughter who's not eating, or they are scared that their son or daughter can't eat without binge eating, and they know that there's vomiting going on in the bathroom. And so I always try to back up from that, take a non-blaming approach. But then that situation with that cheerleader in that inpatient program, it's just like, oh yeah, in that case, you can kind of see where it came from. Okay, I'm going to take a break. We're going to end right now part 1 of the eating disorders lecture.